The next speaker is Dr. Stephen Markowitz. I've had the pleasure of knowing him when he did his training here at Mount Sinai. I've been a colleague of his for many years. He's now in Queens continuing to do meaningful asbestos research and is going to speak on early detection. Steve.
Morning. I want to thank Ms. Grant for spending a few moments in the last really days, weeks of her life, kind of giving us instructions, also encouraging us to continue to work on this. I heard her say that we need to continue research and to advance the science so that people with mesothelioma don't have to suffer so much. And I'm going to talk about some of that, I think. So a little bit early, I forgot to mention actually, Albert Miller is a co-presenter. Albert Miller, Dr. Al Miller is a pulmonary physician who worked with Dr. Selikoff's group in the 70s through into the 80s. Dr. Miller started at Sinai in 1959 and continues to work with us in our lung cancer screening program. So early detection matters, yes, although we bring evidence to that, but can we detect disease early? And I'm going to talk about 3 of the asbestos-related cancers today in my 10 minutes, really. First is the most difficult one, which is malignant mesothelioma. So here are data, relatively recent data, 2015 to 2021 from the NCI database on the 5-year relative survival of mesothelioma, plural mesothelioma, according to different stages stages essentially of diagnosis. And it's divided between localized disease at diagnosis, regional disease, and distant disease. And a quarter of patients with malignant mesothelioma during this time period had I'll discuss the percentage that had localized disease, but that the 5-year survival rate was 25%. The 25% of people with localized disease with plural mesothelioma would still be alive 5 years later, as opposed to disease that was discovered when presented at distant disease, which is only 11% 5-year survival rate. So survival rate in both cases is very low, but you can see that the localized disease has twice the survival rate of people who present with distant disease. And here, if we look at what stage people are at when malignant mesothelioma is diagnosed, you can see, and these data are sort of a broader time period, but about a quarter, 15% plus 13%, about a quarter of them are diagnosed with early stage disease. So some plural mesothelioma is diagnosed early, and those who are diagnosed more on the early side tend to do better than people who have advanced disease, all of which makes some sense. But our problem is that we have no intentional proactive way of screening for malignant mesothelioma in order to detect it early. And this has been worked on now for decades, mostly with biomarkers, blood, plural biomarkers, but without real success. And I have to say that we're going to hear about low-dose CT scan from myself and hopefully from Claudia and David later. But in our program, we've low-dose CT scanned 14,000 workers, nuclear weapons workers. I'll discuss it in a minute. We've detected, we're looking mostly for lung cancers, but we've detected 4 malignant mesotheliomas, and all of them were advanced stage disease. Even the ones that look like they may have been early stage, they were advanced stage disease. And so we have no evidence from our program, and I haven't seen any evidence that low-dose CT, which is so effective with lung cancer, is at all effective with malignant mesothelioma. So now let's talk about colorectal cancer. Not usually a cancer we discuss so much when we talk about asbestos and cancer, but we can look to Dr. Selikoff, actually. This is the 1964 article that Chris referred to before, a landmark article in JAMA where he talks about mostly mesothelioma, mostly lung cancer in the insulators, also non-malignant disease. But if you look at the abstract, he also found, and I'll just read it here, it's on the right-hand side, in addition, an unexpectedly large number of men died of cancer of the stomach, colon, or rectum, 29 compared to 9.4. So he was really the first to point out that colon cancer also is associated with asbestos exposure. And for years, it's gone back and forth because there have been studies that looked at this. And I remember Dr. Landrigan was on an IARC, International Agency for Research Cancer, expert committee in 2012 when they reviewed asbestos. And they decided, of course, that mesothelioma, lung cancer, laryngeal cancer, ovarian cancer were all due to asbestos. But when it came to GI cancer, in particular colon cancer, there was a vote of whether they thought that the data supported whether colorectal cancer was caused by asbestos. And it was a split vote, it was a tie vote, and they did not confirm that asbestos could cause colorectal cancer. So it's not on the official list. But in the meantime, since that time, more data have accumulated, and a very accomplished group based in Canada, thank you, Chris, last year published a meta-analysis, 82 studies, in which they clearly showed that colorectal cancer is increased, not as much, obviously, as mesothelioma, probably not as much as colon cancer. So we can say that colorectal cancer is caused by asbestos. And the good news from the early detection point of view is that we can detect colon cancer early. You know that through colonoscopy, through an annual, what's called a FIT test, a stool test. And so those tools are in place. But what I really want to focus now is on lung cancer, because that's really where the bright side of the story is. Because it's a complete picture now. And I have to give enormous credit to Claudia Henschke and David Yankelevich. They, 26 years ago now, published the study in Lancet, which I think really kicked off the modern era of lung cancer screening. And so lung cancer is the most numerous of cancers among asbestos exposed. Actually, it very considerably outweighs malignant mesothelioma. All the diseases are terrible, but in terms of raw numbers, lung cancer is more common. But more broadly, lung cancer is the #1 cause of cancer death in the US and throughout the world. And we know now that annual low-dose CT scan can detect lung cancer early and reduce lung cancer mortality. And just for those of you less acquainted, I just wanted to show a CT image of a person actually from our program. You can see in the lower left-hand corner, it's the right lung, that there's a distinct 1.6 cm, about 2/3 of an inch mass that is isolated. It's an early stage lung cancer, easily resected by Dr. Flores, although she was from Tennessee, Raja, so it wasn't your patient actually. But in any case, this is the kind of early lung cancer that we can detect with low-dose CT and cure people, so they don't need chemotherapy and can lead normal lives. So the program we've done is sponsored by the Department of Energy since 1998. In 1999, when we read David and Claudia's article, we added lung cancer screening to the medical screening we were doing. This is where we've screened across the country, Portsmouth, Ohio, Paducah, Kentucky, the Los Alamos plant, Sandia, the California labs, Oak Ridge, Tennessee, et cetera, et cetera. And we do this based in New York and Queens. And this is a one-slide summary of really 25 years of work. We've screened over 14,000 workers now. These are people who built our nuclear bombs. So many of them were maintenance, installation, repair workers who would have been exposed to asbestos in the latter part of the 20th century. Others were production workers, operators, also exposed to asbestos to a lesser extent. And we've detected 236 lung cancers so far. And the key fact really is that 72% of them are early stage disease. 72%, 3/4 of them look almost exactly like the CT scan I just showed. Now, this percentage, it's lower than what David and Claudia originally found, but it's the same percentage that the National Cancer Institute study, the big randomized controlled trial, found. And they were working at the major medical centers in the United States. So they were working at the Sloan Ketterings or the Mayo Clinics or the Henry Ford Hospitals, et cetera, in the academic centers under optimal circumstances. What we found in the field, when you were in Oak Ridge, Tennessee, and Paducah, Kentucky, you could replicate that same kind of record. That's how good and robust low-dose CT is in detecting lung cancer. And so you don't see Dr. Selikoff in this slide, but let me explain this slide, and then you will see Dr. Selikoff's influence here. This is our scanner in Oak Ridge, Tennessee. And behind the scanner is the Union Hall. This is the Atomic Trade Labor Council, now the United Steelworkers. This is where the workers come for all their membership obligations and benefits and questions they have in relation to the unions. And we decided to put our scanner there because we wanted to send the message that this is a partnership with the union. This is a collaboration with these unions in Oak Ridge. And we thought that that would send a message, multiple messages actually, but one of the things we realized over time was that it was extremely influential, I think, in getting great turnout for lung cancer screening. And I think this is probably the only real data slide I show, but what we show here is T1 is your first annual low-dose CT. You have your baseline, your first annual is T1, T2 is your second annual scan, T3, et cetera. So we've been doing this for a long time, but we just looked at the last 10 years of data. And this is the percentage of people who return for their annual low-dose CT. It's at 90, we get a 90% return rate, which is absolutely remarkable. And I think it's because this is a partnership. But if you look at the general population in the US, the adherence rate on the first annual or second annual, and this is the lower part of the slide, it's a 50% adherence rate. We get 90% adherence rate. So it can be done, but it requires a partnership. It requires a different kind of approach. And I mean, let's end on making this point that setting aside workers and asbestos, but the general population who are eligible for low-dose CT in the US based on age and smoking only, that group, less than 13% are taking advantage of low-dose CT. This is just an enormously waste of an opportunity. And we can do this. We can save many lives. There are 120,000 people who die per year of lung cancer. Most of them need only meet Raja for a brief, maybe a one-day visit in the hospital. We get to resect that early lung cancer, and they can lead a normal life. And we need to make this happen. When we stand the government back up, this is the first place that we can start to promote public health. Thank you.